Welcome to this explainer. Imagine a cough. Not just, a tickle from a passing cold, but an unending, severe, wet cough that never truly goes away. It disrupts your sleep, it completely exhausts your body, and it hints at a microscopic, relentless battle raging deep within your chest. Today, we're unraveling the medical mystery of bronchiectasis. We're going to use the source data to visualize exactly how a single vulnerability in the lungs can trigger this massive self-destructive loop and how modern medicine attempts to break it.
Okay, let's dive right into our roadmap for today's medical investigation. We'll be covering 1. The unending cough, 2. The vicious cycle, 3. Mapping the lung damage, 4. Spotting the clues, and 5. Breaking the cycle.
All right, starting off with part 1, the unending cough, and defining the disease.
Now, what's really interesting here is the sheer gravity of this definition. Bronchiectasis is an obstructive lung disease characterized by the irreversible dilation and destruction of the major bronchi and bronchial walls. I really want you to focus on that word, irreversible. Basically, the airways, those crucial branching tubes that carry oxygen deep into your body, they're being stretched out, widened, and structurally destroyed. They just can't bounce back. Because of that structural collapse, patients face a pretty harrowing set of daily physical symptoms. The classic hallmark, a persistent, chronic cough. And this isn't a dry cough. It produces thick, purulent, which just means pus-filled, sputum. If a doctor were to listen to their chest, they'd frequently hear crackles and wheezing. Over time, patients can even develop digital clubbing. That's a crazy physical change where the fingertips actually become enlarged and the nails curve, alongside mild to moderate airflow obstruction. So as you can imagine, the stakes for the patient's daily quality of life are incredibly high. But it's not just a daily chronic struggle, right? There is a sudden, extreme danger lurking in the background. The ultimate danger here is massive hemoptysis. That's the medical term for coughing up large amounts of blood. So how does that even happen? Well, the chronic inflammation going on inside the lungs essentially erodes the hypertrophied or enlarged bronchial arteries that are just trying to supply blood to the damaged airways. When those arteries rupture, boom, it leads to sudden, life-threatening bleeding. Moving right along to part 2, the vicious cycle, basically microscopic warfare. So we know what the disease looks like on the outside, but what is the underlying biological why behind it all? It actually comes down to a 4-step loop, famously known as the vicious cycle hypothesis. It all starts with step 1, impaired clearance. Some underlying vulnerability, maybe a genetic defect or a really severe past infection, stops the lungs from effectively sweeping out mucus. That leads straight to step 2, microbial colonization. Pathogens like Pseudomonas aeruginosa or Haemophilus influenza basically set up camp in that stagnant mucus. This triggers step 3, a massive inflammatory response. Your immune system rushes in white blood cells called neutrophils, and they release these highly destructive proteases like neutrophil elastase, along with reactive oxygen species. Which brings us to step 4, airway destruction. The elastin, smooth muscle, and cartilage of the airway walls are just obliterated. And here's the terrible trap. That destruction further impairs the lung's ability to clear secretions, looping us right back to step 1. The infection and the damage just keep fueling each other in this never-ending loop. All right, part 3, mapping the lung damage, using geography as a clue. Let's see how this builds, because exactly where the structural damage happens in the lungs actually reveals what caused it. It's almost like a crime scene. If a doctor sees damage concentrated mostly in the upper lung fields, the common culprits are usually cystic fibrosis or post-radiation fibrosis. If it's down in the lower fields, they'll suspect chronic aspiration, immunodeficiencies, or traction bronchiectasis, which is wild. It's where the airways are literally pulled open by surrounding scar tissue from fibrotic lung diseases. What if it's in the mid-lung fields? That's classically linked to non-tuberculous mycobacterial, or NTM, infections. This particular mid-lung presentation is often seen in older, thin, non-smoking women, and it's sometimes playfully called Lady Windermere syndrome after the Oscar Wilde character who constantly suppressed her coughs. Finally, if the central airways are hit the hardest, doctors are looking for allergic bronchopulmonary aspergillosis, an immune reaction to a fungus, or congenital cartilage deficiencies. But despite all of this brilliant medical profiling, there's a totally shocking twist in the data. Just look at this number, 25 to 50%. In up to half of all bronchiectasis cases, the exact cause remains totally unknown. It is classified as completely idiopathic. Literally half the time, the trigger for this devastating cycle is just a complete medical mystery. No way, right? Okay, let's head into part 4, spotting the clues.
reading the CT scan.
And this brilliantly illustrates how we actually visualize that destruction. The gold standard for diagnosis is the high-resolution chest CT, and doctors are looking for specific visual metaphors, like the signet ring sign. Imagine a literal ring you'd wear on your finger. In a healthy lung, an airway and its accompanying blood vessel run side by side and are, roughly the exact same size. But in bronchiectasis, when you look at a cross-section on a scan, the pathologically dilated airway is at least 1.5 times larger than its companion vessel. So the giant airway looks like the big jewel, and the normal blood vessel looks like the band of the ring. Another huge visual clue is the tram track sign. Usually, normal, healthy airways taper gently as they reach out toward the edges of the lungs, kind of like branches on a tree. But these diseased airways, they don't taper because they're irreversibly widened and thickened. When you view them lengthwise on a CT scan, they look exactly like thick, parallel train tracks running straight through the lung tissue.
And finally, we have the incredibly evocative tree-in-bud pattern. This indicates that the tiny, smaller airways further down the line are completely impacted and choked with inspiciated, which is just a fancy medical word for severely thickened, mucus and secretions. It paints such a vivid, physical picture of that impaired clearance we talked about earlier, doesn't it? Which brings us to our final section, Part 5, Breaking the Cycle. Therapeutic management. So now that we can clearly diagnose the destruction, how on earth do we stop it? Well, the cornerstone of daily survival here isn't actually just popping pills. It is intense, physical, mechanical work. It's called bronchial hygiene. Patients have to actively mobilize and clear those secretions to manually break that vicious cycle. We're talking adequate hydration to thin the mucus, using mucolytics and hyperosmolar agents like nebulized hypertonic saline. And then there's mechanical chest physiotherapy. This involves literal physical force, using flutter valves, postural drainage, or even wearing these crazy high-frequency chest wall oscillation vests that violently vibrate the chest to literally shake the mucus loose. Now, beyond the physical clearing, there's a really distinct tactical difference in how medications are used. For acute exacerbations, sudden flare-ups with a lot more pus and sputum, doctors go in with short 7 to 14-day courses of targeted antibiotics aimed at specific pathogens. But for patients dealing with frequent, recurrent flare-ups, the strategy shifts to suppressive therapies. This is a long-term war to reduce the overall microbial load, utilizing things like inhaled aerosolized antibiotics or prolonged courses of a specific class of antibiotics called macrolides, like azithromycin.
But right here we need to pause because the source data highlights a stark, absolutely critical clinical warning. Macrolides are great, right? They have both antimicrobial and anti-inflammatory properties. However, a doctor absolutely must rule out an active NTM, that's non-tuberculous mycobacterial, infection before starting chronic macrolide therapy. If they skip that step and prescribe macrolides while NTM is present, they risk breeding highly resistant mycobacteria. So it is a massive, high-stakes balancing act. Finally, when the disease is refractory, meaning when the daily hygiene and the long-term antibiotics just aren't working anymore, we reach the advanced interventions. These are the drastic measures. If massive, life-threatening hemoptysis happens, doctors might perform a bronchial artery embolization to basically plug up the bleeding vessels. If the severe disease is really localized to just one specific lobe of the lung, they might surgically resect or just cut out that destroyed piece. And for end-stage diffuse disease that's ravaging both lungs, the final extreme option is a bilateral lung transplantation. So we've seen how modern medicine maps the damage, visualizes the signs, and deploys literally everything from vibrating vests to double lung transplants to fight this vicious cycle. But I want to leave you with one lingering thought. We can manage the symptoms, sure, and we can slow the destruction. But how do we solve the mystery of the up to 50% of cases that remain completely idiopathic? Until we unlock what actually triggers the cycle in that unknown half, this microscopic battle is just going to continue. Thanks for joining me on this explainer, and keep questioning what we don't yet know.